Thank you very much, MC. As I was introduced, my name is Pascal Mwele, and I'll be the moderator for the session. And on this session today, first of all, thank you for taking time to attend this session. And on this session, the panelists will be sharing lessons learned from the COVID-19 epidemic, informed efforts to strengthen coordination and adoption of surveillance informatics in Kenya. They will also summarize the Ministry of Health, Kenya's Ministry of Health plans to leverage electronic health records to automate passive case detection, flagging, line listing, and reporting of suspected integrated disease surveillance and response diseases. We will hear from the representatives of the Ministry of Health Kenya, that's Dr. Okunga, CDC Kenya, CDC Atlanta, ITEC, and Palladium. So the format of the session, we will have two presenters, that's Dr. Odhiambo and Dr. Okunga, starting with Dr. Okunga, who will take us through a few slides, and then we'll have an interactive session for all the panelists. Over to Dr. Okunga.
Good afternoon, all colleagues in the hall. So I think the introduction was adequate, only that I also need to slightly add that I'm now transitioning to zoonotic disease unit from disease surveillance and response unit under the same division. So we'll be just providing some insights from the ministry on our surveillance systems. I know in this country we're implementing integrated disease surveillance and response as part of the continental strategy, although it's also informed by EHR and the global health security agenda. And largely what we are trying to provide today is the lessons we've learned during COVID and what we need to take forward. So currently, the ministry has at least 50 priority diseases that we are monitoring. And our surveillance system is largely integrated. So a lot of vertical systems have been put together in one system. Although we still have a few vertical systems that are disease specific, mainly for the TB program, malaria program, and the HIV program. However, most of the other infectious diseases are integrated into one system. So we report, our reporting frequency is based on the risk of the disease. So we have immediately reportable diseases, which are mainly the epidemic-prone diseases. Then we also have the diseases we report every week, and diseases we report so then there are also diseases we report monthly. So you'll find most of the diseases that are epidemic prone and the diseases that are due for eradication or elimination shall be reported immediately or weekly. So you'll have a bulletin every week. Now, the reporting levels, we have reporting right from the community level, then to the third administrative level, which is the sub-county, then the second administrative level, which is the county, and then the national level. And we largely have two surveillance systems, two main approaches. The indicator-based, which is really what is formal within the health facilities, and then event-based surveillance, which is riding mainly on our community health services program. As you may know, In the country, we've now recruited more than 100,000 community health promoters. So those are now our frontline surveillance officers in the community. So in terms of our strategy, we basically look at four main areas. So epidemic preparedness and response. And this, we are implementing the 717 approach in the country. Then data management. This is an area after COVID, we've had a data modernization initiative supported by US CDC. And I'm sure I will speak to that as we go along. And basically what the data management is supposed to do for us is digitization of our systems, ensuring interoperability of our various siloed systems, and being able to put out outputs that can be actionable in real time. Then we also have the third pillar, which is around laboratory capacity. So we have the laboratory capacity and the information systems to support the laboratory. The laboratories in terms of information systems, the issues around genomic surveillance, the issues around bioinformatics that need to be mainstreamed in our routine public health laboratories. Then, of course, the other big issue, the bigger pillar is coordination, because we have two layers of administration in the country. We have the national government and a devolved system of government at the county, sub-county level. So you need to be able to properly coordinate those two levels so that you're able to get the best out of the systems. Now, some of the issues that will come up, during the COVID era, we all saw the challenges that came up because of siloed systems. The siloed system, the main surveillance system was picking the epi data. The lab systems were picking the results. We had systems at points of entry. We had systems around tracking truck drivers and many other systems in different places. So bringing together those systems to speak to each other is one of our main priorities. The other, of course, is a lot of our systems during COVID were also paper-based. And the sheer workload that came with the COVID epidemic, particularly a pandemic after the first 6 months, the information overload was quite much. So this is also an area we need to look at. And then in that kind of environment, you also end up with a lot of information loss in the different facilities and the quarantine facilities, the isolation facilities. So these are some of the things we really need to look at. So this is our information flow in the integrated disease surveillance system. We have the mainstream system where we have the epi data being collected through the disease surveillance and response unit, but we also have case-based information that is going to the labs before it comes back to the disease surveillance and response unit. And there are different labs. We have the main national public health laboratories, but you also have the KEMRI laboratories that are supporting public health surveillance. And these labs receive data from the counties, and there are some basic tools there listed that we use. I know there are a few that can be added. So in looking at our data, what we've now added is below the green, the community health information system. So we have a community health information system, which we call the electronic community health information system, or EHRs, for those of you that are familiar with our systems. This was the old setup, a lot of paper forms, which have to be transformed into registers, then summary forms, and then the facilities were to carry those hard copies to the sub-county. And then the sub-county uploads to the health information system. There's a bit of data analysis at that sub-county level, but this is also very minimal, so this is something that needs to be strengthened. Most of our data analysis is happening at national level. So, moving forward, the issues we now want to address are issues around the siloed systems. How do we get the systems to talk to each other? The issues around downtimes of the Kenya Health Information System sometimes, which affects our reporting, so we need to fix that. There are issues around standardization through of the different variables in the different reporting forms. And this is something we're addressing through the data modernization initiatives, both in the forms we are uploading on the repositories and also the public health emergency management system. Then there's the issue of technology. We have more than probably 13,000 health facilities in the country. A large proportion of them do not have EMRs. So this inadequacy in terms of the physical ICT infrastructure, and then also the ICT support in terms of airtime, bundles, and all these things still need to be addressed. But in view of the bigger government agenda about digitization of all government services, this is something that is being prioritized going forward. Then, of course, the other issue is hosting of these information systems, which, as per government guidelines, have to be hosted in government facilities, and there are rules and governance structures that have been defined, and this is being worked on. Of course, the data privacy. We have a Data Protection Act in the country, which is guiding us on all this, and it's available for everybody to look at. Then in terms of implementation, so community level implementation, we have mobile phones at the community level. So all the about 100,000, 110 community health promoters have phones, and with a system that we are calling EHRs. So this has been linked to the indicator-based system. So we think that that is something that can be quickly moved forward. Then there's been the issue of the unique personal identifiers, which is being worked on under the bigger government agenda on digital health. We believe that once this is fixed, it will also help us standardize a lot of our information systems. And then finally, feedback. As I indicated, a lot of our surveillance feedback is through, to the lower levels, is through the weekly bulletins. Upward, we also report towards to WHO and our other stakeholders, but this can be improved to make it more real-time by providing dashboards in the system that can quickly provide particularly the lower level surveillance officers with real-time feedback. think most of this we've talked about the same, and this is largely the issues around insufficient case level data systems, the unique identifiers to identify clients, issues around difficulty in linking contacts and cases. These are the things we also saw during COVID because of lack of UPIs, and then challenges linking lab data and AP data, POE data, and so on. So, why are we prioritizing public health digitization or electronic surveillance? So, first, we're able to get the information fairly real time. We're also able to simplify the work for the surveillance officers at the lower levels and even at national level through digitization of the tools. We're also able to look at historical data by getting the data into repositories that we can pull from. And that historical data is what will form thresholds for us in terms going forward. Then you also have the issue of removing duplication. I think this will be a big gain. Then sharing of information with different stakeholders will be easier. The government will still remain the custodian of these health solutions in line with the current regulations. Then the issues around centralized data repositories and hosting, which has already been digitized. All this work is being done under the auspices of a digitization technical working group that brings together all the different actors in that space, from the Ministry of Health, ICT, the counties, our partners, and I think the agenda is moving well. So if I know Dr. Jacob will be speaking to how we are looking at EMRs for passive surveillance, but largely what we are saying is that we can create multi-channel e-surveillance systems, linking several data sources, then coordination will be easier, and we can also insert predictive analytics within the system. So thank you very much, and back to you, moderator.
Thank you very much, Dr. Okunga, for providing the context, lessons learned, and the problem statement. So I'll invite Dr. Jacob to come and give an overview of the solution, and then we'll get into the panel discussions. Dr. Jacob.
Yes, good afternoon, everyone. In the interest of time, I'll keep this very targeted and focused, not to repeat what Dr. Okunga has mentioned. So I'll just focus on one aspect of public health surveillance that links digital health systems and routine data collection systems. So even though we are looking at routine surveillance systems, lab, AP interface, and outbreak response, I'll focus more on the routine surveillance systems using routine systems. But to start us off, is to look at our facility context. Dr. Okunga mentioned that there's a nationwide digitization effort going on. EMRs are being deployed, but the motivation is mainly, clinical care. Surveillance is a secondary use case that is being realized because of that. We also know that because of largely paper-based environment, most providers do not know how to use these digital health systems adequately. The surveillance process in the past has been kind of parallel to the clinical care process, so that then the paper-based systems are what is used to consolidate the data, but clinicians just see patients using their systems as before. Now, we know that this leads to inadequate data use activities across board. And then case detection is dependent on the clinicians, which means that there is sometimes the risk that standardization of case definitions may not be applied to detecting and reporting cases. And we know that this burden then lands on the surveillance officer's desk, and that leads to a number of issues that I don't think I'll go through in this process, but basically redundancies and inefficiencies in surveillance data collection. Now, over the years, through funding from HIV, most of the US government agencies have been investing in digital health systems that have done very well for HIV. The nationwide digitization effort is now leading to a scale-up of facility-wide systems that operate in outpatient departments, inpatient departments, where a lot of cases are diagnosed and reported, but also in lab systems, where then confirmations of this diagnosis are made. There is an opportunity to build on this foundation, to build sustainable and routinized surveillance systems that leverage resources that are already available at the front line. So how do we want to do this? The principle is collect once, use multiple times. Clinicians just want to see patients using the systems and record what they do. But then surveillance officers need that data to be able to monitor public health events that are under surveillance. And then there are multiple use cases. For today, we are going to focus on routine surveillance. How do we then harvest this data that's coming from clinical care process for surveillance use cases? So what we came up with is the concept of EMR-enabled surveillance that takes care of the different surveillance approaches. Passive collection of surveillance data sets that allow you to ensure that suspected cases can be detected and line listed, syndromic surveillance, which is part of our arsenal for surveillance, and assisted case detection, where the EMRs assist in detecting cases. Then there is case-based surveillance for diseases that are reported at case level, and then through automated indicator reporting, we can be able to enable routinized reporting that is near real, that is basically efficiently done through electronic systems. Now, why do we do this? To make sure we standardize case definitions assisted by the system, automate referral and reporting of cases, ensuring that we can be able to scale up and build on the backbone that has been done before, link AP and lab interfaces based on a unique person identification regime, but also promote data security, because rolling out digital systems come with those risks, but then also providing new data sets for public health surveillance. So what did we do? We basically standardized forms for data collection in the electronic health record systems, automated case definitions and built them in the frontline health information systems, and then ensure that we can be able to improve completeness of data through validations within the system. Then basing on the wide network of electronic health record systems, we're able to now start unlocking surveillance data flow within the systems. But then the Ministry of Health is rolling out the digital health superhighway, at the core of which is a client registry to enable unique person identifications. We are connecting to that system so that any surveillance data sets can be linked to unique individuals in the healthcare systems. So the three areas that we are supporting using this approach is syndromic surveillance, the most common of which we know is influenza-like illnesses and severe acute respiratory illnesses, but there are other syndromes that we monitor, passive collection of surveillance data sets, but also indicator-based surveillance. Now, the three areas that I'll be focusing on today's presentation is three syndromes: influenza-like illness syndrome, gastrointestinal syndrome, and respiratory syndrome. And this is basically just providing examples about how this is working in practice as we roll out this approach. So the first step is assisted case detection. How does this work? Using a case definition built in the EMR, providers, the system is able to identify and flag a case to a provider using flags that are available in the system. So this applies the Ministry of Health case definition for diseases and then flags it for a patient. In addition to flagging the cases, we also ensure that clinicians can then list those cases. So these are sample data, so please don't think this is personally identifiable data, but you can see on the right-hand side column, the cases that have been flagged can actually be listed for clients, and you can be able to basically filter out others and just focus on the cases that you are monitoring over time. This makes the surveillance process easier at the front line, a process that used to rely on surveillance officers to basically abstract data from clinical records for the purposes of surveillance. Then there is frontline analytics at the facility level, providing basically charts that show the frontline healthcare workers of the conditions that are being diagnosed as they are diagnosed over time. And these charts are in near real time. Schedulers run every 5 minutes to make sure that the dashboards are always updated. And then there is now disease trends. We are now able to basically present this data as charts that tells you the trends in occurrence of the diseases. And what we will see on this state is that in the bar, the histograms basically show you the occurrence of diseases over time, and then in the line graphs that are there, it shows you the occurrence of different diagnoses clinicians have made as time goes by. So that then when there is an upsurge of cases, you can be able to tell which particular diagnosis is responsible for that particular upsurge. This is data that is being collected in real time at facilities and can actually be able to provide insights and early evidence that there is actually an outbreak that is coming up. This is for diarrheal diseases as an example. For malaria, this is one example that we have built. And on top of that, then, just in line with AP principles, we are organizing the data in place, person, and time. And these are just both some of the 2 dimensions on which we are basing the data viewpoint. Now, in summary, we know that routine digital health systems have the potential to transform surveillance data collection. This has been proven in HIV context, and it is time that we engage clinicians in surveillance process through this. We also know that public health decision supports begin at the front line, so that then public health practitioners can basically be the secondary users of public health decision support features. That's the end of my presentation, Pascal.
Thank you very much. Let's appreciate the 2 presenters. Once again, please. And so I'm going to shift to the panelists, and I'll start with you, Zen, because you have a global perspective. So you're based in CDC Atlanta. You do provide oversight over many countries. So I have 2 questions for you. One is if you could talk about the Data Modernization Initiative, what it is, what it was all about, what problems it was meant to solve. And then in the specific case of Kenya, if you could please talk about what challenges, I think Dr. Okunga talked about challenges. What challenges that Dr. Okunga has shared, you've seen cut across in other countries, but also what opportunities you've seen that have been in Kenya that have been uniquely addressed by this solution?
Thank you. So the first question, the global public health data innovation was an opportunity that came across because domestically at CDC, we understood that we had many of the same challenges with our systems that other countries had around the world. And so had planned to invest significantly in transforming that infrastructure really from the ground up, from the sources of data. What do we need to do to strengthen that? How do we move data across the ecosystem so that they're available to public health authorities? How do we consolidate that information so that it's usable? And how do we secure it? And then how do we share it with others? So in the US, data comes to local health departments and state health departments, and then is shared at the national level with CDC afterwards. I think that the issues at the global level are largely the same. We get data from the same sources. We have to move them in the same way. We have to secure the transmission. We have to enable the use of that information. We have to have intelligent policy about it. So the global public health data innovation was an opportunity to take some of those lessons learned and some of the tools and the artifacts that were produced domestically and then share them across the globe. In many cases, to some cases we had to adapt them, but mostly it's the same. It was an opportunity to actually provide like a 3-year field test where we had an opportunity to work with a limited number of countries, including Kenya, to see whether or not those improvements could meaningfully impact improvements at the local level. I would say that in terms of, I don't think of Kenya as being unique in any way. And I don't know that the problems, when I came into this space, we often thought that what was needed in what's been called resource constrained settings was radically different because the technologies were different, because the ability to finance is different. And so many of the solutions when I started, which is 15 years ago, were quite different. I don't think that's true anymore. I think that the world is shrinking in many important ways, including the adaptation of technology across the globe. So not only are the needs for data to protect the health of the public the same, but I think that the technologies that can be used to build that up are also increasingly more the same.
Great, thank you very much. And just as a follow-up question, increasingly we are seeing for surveillance and other use cases, the need to standardize data sets. What has been your experience in countries adopting standards and standardized data sets to be able to provide a comprehensive picture of the state of the surveillance systems?
No, thank you. You know, the standardization is a complicated problem because in many ways, in order to fully articulate the size of the problem, you have a complex model, you have the technology has to be able to adapt to any kind of data. But at a practical level, what you really want to do is actually be able to demonstrate the sharing of data from one source to another and the meaningful use of that. And often the technical choices you have to make to do the latter are not the same. They're related, but they're not identical to the problem of articulating a standard that could be comprehensive across any condition, across time. So you often have this tension between the practical and the theoretical. I think we need to address that issue. I think we need to articulate what all of the challenges are and then start converging. I have a colleague who calls it, just-in-time interoperability, that we need to stay focused. The real issue is that we need to get data that people are using. And if you can do that point to point, that's not necessarily efficient, but it's a good place to start. And once you have functional systems that people are actually using, they can be improved over time. People can add to them. And then that overall comprehensive vision needs to guide that effort, but it's not going to be perfect. It can improve over time.
Thank you very much. So to you, Dr. Penina. I think what Dr. Jacob has presented could present a tension between what the clinicians are doing at the front lines and what the public health teams are looking for and looking to get out of data. How can ministries of health help to sort of like broker that tension between prioritizing service delivery, but also ensuring that the tools and the systems that are being used at the front lines are addressing public health priorities?
Thank you, Pascal, and good afternoon, everyone. So that's a good question, and like Jacob presented, the solution that he talked about passive surveillance is the ability of the clinicians to participate in surveillance without actually knowing they are doing surveillance, which they have always done, except that they would be providing care, but then they would have additional tools that then would have to document the surveillance elements that were important for public health surveillance. Now, the Minister of Health, of course, is very central and needs to be in the driving seat to drive that conversation. Like that as healthcare workers, whether you're a community health promoter or you're a clinician in a facility or in a private health facility, we do need to get specific elements or data from the people that we are seeing to inform decisions that impact all of us as a population. So the Minister of Health being able to provide that environment or the tools that allow clinicians to just do their work while the surveillance data finds its way to a repository, to a place where the public health professionals can then look at that information and make decisions that pertain to that population. For example, the work on passive surveillance, which Jacob did present, it allows us to leverage on the resources and investments have been done for many, many, many years with the HIV/TB world to actually now start the digital transformation of public health surveillance data. It allows us not to start from the scratch, not to have to develop parallel tools, but to actually utilize the tools that have already been existing, like clinicians are already using them. I think one of them is providing the public, like EIDSR, and I know it wasn't specified here, the EIDSR roadmap that is linking surveillance data to the HIE, which has been talked about in this conference a number of times, so that the work that we are doing as surveillance can inform the decisions for public health professionals.
Excellent. And then a follow-up question to that is, what is the role? I think on Monday there was the overview given about the Kenya Digital Health Superhighway, the role that policies, the right legal framework, the role that such infrastructure is important in terms of driving digital transformation. For surveillance, there is a draft e-surveillance strategy. How has that journey been, and what do you see as the potential and the lessons that could be derived out of coming up with an e-surveillance strategy? Why is it necessary, and what could it help in facilitating convergence of investments and efforts in surveillance?
Thank you. And I'll just go back to one of the comments that was made by one of the presenters from Kenya about the role of, or the usefulness of the convergence workshop. So surveillance was represented during the convergence workshop that actually defined the superhighway that has been described here, because surveillance is part of the digital transformation for the whole of government. Now, when you find yourself in that architecture which has been defined, then it means partners who are working in health or who are working in public health surveillance space can be able to find their priorities, can be able to align their priorities, and also find areas and gaps and priorities that they can fund that align both to their priorities and goals, but also they contribute to the whole system itself. So I'll give an example. One of them, for example, is there was identified the need for a surveillance repository, because for the longest, surveillance data, which Dr. Okunga and most of us who have worked in this space have been generating over time, was in various different silos that he mentioned. So one of the projects that we identified was coming up with a surveillance repository that allows various workflows, some which have been digitized, like from the EMRs, some which would need additional tools because the patients are not necessarily being detected at the health facility, to generate that data, to collect it in a repository, also be able to visualize that information. That is a big game changer for surveillance, specifically where we haven't had a repository before. Now, without a roadmap or an architecture that shows partners areas that they can actually plug in and support, then it means that we will do standalone initiatives that will not contribute to the whole good. And digitization or digital transformation is a very expensive, it's a very resource intensive initiative, and there is no one partner who can be able to fund that. But this allows different partners to be able to plug in and to work towards a common good. Yeah.
Okay, thank you very much. Now I'll turn my attention to Dr. Okunga. From the ministry's perspective, you provided the challenges that we faced as a country in our COVID response, the fragmentation of systems and so on and so forth. What does such an initiative, and knowing that there is now a whole digital transformation journey that Kenya is on, riding on the digital health superhighway, what is the intention of such an investment going to position Kenya as a country moving forward, should there be another outbreak or a pandemic of the scale and proportion such as COVID-19?
Thank you, Pascal, for that. And from the outset, we must say we are already monitoring ongoing outbreaks. We already have the Mpox outbreak that is ongoing, and we are using tools built out of this DMI to monitor the epi situation, to monitor the interventions and to also monitor the resources that are going into the system. So under ADAM, that is there. The other thing that we are using the ADAM tool to support us on is to conduct, for the counties to conduct self-assessments of their response capacities. So that is fairly mature now. But we also have the other bit, which is now the repository, which we call SHIELD, which is now supposed to put together all our data work. So as we said, our main work is twofold: early warning systems and timely response. So in terms of early warning systems, these are the things we are doing with the passive surveillance. This is what we are doing with EBS. These are the things we are doing through dashboards and digitization. In terms of response, the idea is we want to build capacity of surveillance officers to detect early signals, to detect signals early and respond. It comes with a bit of challenges in terms of you need to support them to be able to go to the field, investigate signals, and that requires logistical support. But the government is working around that with the support from various partners. So we think this initiative is very central to the work we are doing in terms of our overall public health emergency management, and even the bigger work that we are doing around pandemic preparedness and response. I think that we now have a fairly good policy framework as a country. We need to work a little more on the legal and institutional frameworks. There's a bit of work. We have a bit of support structures there, but we need to add a little on that. But technically what we are saying is that we don't want to add work to healthcare workers. We want to make their work easier. So if you demonstrated what Jacob demonstrated, technically, if a clinician is seated in an outpatient department, they'll collect information on symptoms in an EMR. So there's nothing more they'll be expected to do in terms of data collection from that passive EMR. That information will automatically produce a dashboard. So the clinician is benefiting from an automated dashboard without increasing their workload. That's one of the benefits of that particular system. Where we have interoperability between what we are collecting in community event-based surveillance and the indicator-based surveillance, we've also, those issues are basically dashboards that nobody is struggling to produce, they just need to utilize. And finally, what you've asked about standardization or interoperability, I think what the technical working group has largely agreed on is that different facilities, public and private, have different systems. So you go the way of standardization, there is a big challenge. The actual ICT and the information system, but interoperability seems to be where we are going.
Thank you very much, Dr. Okunga. Now I'll turn my attention to Sonora. And all this needs a well-trained workforce. What are your experiences in ensuring that the workforce is aware and has the right skill and capacity to maintain the consistent use of such digital systems?
Yeah, thanks for your question, and thanks everybody for being here. I think we all have talked about and heard today that digitization of surveillance systems or any systems is a big undertaking. It's very resource intensive, and ultimately it will be people, right, who are using, implementing, maintaining, and managing those systems. So we've a number of different workforce activities. For sake of time, won't go into all of them. But we have been working with CDC on what really targeting different cadres of the public health workforce, from the senior level leadership, mid-level, and the actual implementers. Because I think, as we've heard from a lot of folks here this week, we're not going to achieve digitization through purely a top-down or a bottom-up approach. So we're calling this the triple IG framework that refers to the different names of these trainings and the underlying framework for making organizations more informatics savvy. Maybe to call out one particular project that we're working on relevant to this group is some work with the Africa CDC on their new African Epidemic Services public health informatics track. So our group has been supporting the curriculum development, but I think there have been a lot of best practices there that make sure we're tying back into how to ensure that we're supporting surveillance system digitization and the actual needs that we're seeing pop up, to make sure that organizations are staffed from the bottom up to have capabilities to be flexible and address emerging diseases as we see them.
Thank you. Follow-up question.
Yeah.
What are you seeing as some novel approaches to deliver the training, or to curate knowledge, or to challenge the traditional approaches, top-down, bottom-up? Any things that stand out? Any approaches that stand out?
Yeah, that's a great question in terms of novel approaches. I think making the connections in a more formal way from the challenges we're hearing at the implementer level, making sure we're escalating that to ministry folks who we're talking to about how to operationalize their existing digital health strategies, and then creating venues for a higher level leadership to make sure that's reflected. I don't think this is necessarily a novel strategy, but an important one to reinforce is that whenever you're approaching any of these training strategies or training programming, ensuring that it's in alignment with existing strategies. Our work on the Africa CDC project is in alignment with the AU's digital health strategy. And I think making sure we're moving in unison together is really critical to building trust and making sure that we're upskilling folks so that they're ready to work within the environment that's being set by existing governance and policies.
Excellent. Thank you very much. Dr. Jacob, you've shared your journey in supporting, building on the PEPFAR investment to embed automated case definitions and so on and so forth. Out of that experience, what would you say are your key lessons learned or principles that you've picked out of the experience and that you'd hope to build on?
Yeah, thank you for that. So I think the first thing is to design with the users. You can assume that everyone has been part of the HIV journey, but they have not. They have their own experiences that they would like to take. And in that journey, then there are different categories of people. There are users who actually work with the systems. There are clients who expect the data from the systems. So that's a very important lesson that we learned. The second is branding. You need ownership of the solution so that then as a surveillance expert, you know this is your solution. You're building on past investments. That's branded in a certain way. You need to brand it different. The third is to make sure that you, in surveillance, the data is the most important thing at the end of the day. Case management, yes, is part of controlling epidemics, but the data is very, very essential. So when you come to the space with a leaning towards more of the clinical care side of things, you need to really reflect and balance between the clinical care and the surveillance data set. And all of them have their own needs, okay? And then the final thing is that there's a lot of lessons learned in how surveillance is structured in our local context, which is very different and dynamic, There's been a lot of lessons learned about how that structure is done that allows you then to link to understand how routine surveillance systems link with lab confirmation and link with outbreak response initiatives. And there are nuances in there that you have to take care of as you do the transition. Then, of course, the final thing is change management at all levels. Okay, Traditionally, solutions that have been done using, manual paper-based systems, when you are transitioning, surveillance continues. It does not stop. So you have to probably find a way of managing the transition in a way. There's a hybrid process along the way before you finally transition to digital systems, and that takes time. Thank you.
Thank you very much. I'm going to put Zen on the spot, building off of the question that I've asked Dr. Jacob. Again, from a global perspective, what lessons can we pick out of Kenya that could be applied elsewhere? I know you made a comment that, we are no longer having unique scenarios in different countries, so we are more or less experiencing more or less the same challenges, but also more or less the same opportunities. What would your take be out of this experience in embedding passive surveillance in routine systems?
There's a lot of different questions there. Let me just go in a slightly different direction. Some of the things that COVID exposed is the need to bring data together and really from multiple sources, many of which are known, but some of which are not. The wastewater surveillance that just mentioned emerged as an area. So when we're thinking about building infrastructure that is going to be robust and scalable, we have to think about how we can accommodate for new conditions and how rapidly can we actually define what those needs are, including the technical specifications, put security around it, move it together. I think what struck me most about my recent visits to Kenya is really how much progress has been made. I find the work here, one, very pragmatic, but also quite detailed and purposeful. The movement to embrace the larger technical revolution through, for example, the encroachment into cloud computing, I think has been a very important step. In most of the countries where I've been working, we thought of our task under GPHDI as just removing barriers to cloud adoption. Kenya has actually begun to do that. That enables a lot of technical capabilities, especially around things like scalability and flexibility that you wouldn't have otherwise. You can adopt them all at the same time. The other point that I think needs more attention, I know everybody talks about privacy and security. The threats from an interconnected world are actually increasing quite rapidly, and to be able to adequately protect our systems, not just the privacy of the systems, but the basic operational integrity of those systems, is going to require like an order of magnitude more sophistication in the way we're thinking about that. So we have to, that step into leveraging that technical innovation that exists around the globe is a critically important one.
Okay, thank you very much. A round of applause for the panelists. And that's our time. Thank you very much for taking time to attend this session.